All right, you guys, welcome back to the I Believe podcast. I'm your host, Danae, and today I'm joined by a new ocular oncologist in town from Irvine, California, in Orange County. Say hi to Dr. Oakey. Zach, can you just give us a little bit of the background for your TikTok channel? Can you tell us what that is and what kind of content you create as an ocular oncologist and why?
Yeah, I started TikTok because every time I'd meet someone, I noticed I was like waving my hands a lot, trying to describe like the eye, where's the retina, where's the lens, and I thought, well, why don't I actually in my exam room have a TV sitting there with like a drawing of the eye and so on, and it got to the point where I had all these skills built up, so I decided if someone wants to learn more about what we're talking about, they can go to some channel of mine and look at it. So, and besides that, there are a lot of people out there who they're recently diagnosed with something. Maybe they live in some other area of the country and they want to learn more about it. And I felt like that's a service to the public. So, in a little 3 minute increment, I can kind of deliver a little message, and I think it helps people out.
Yeah. So, what are some of the kind of things that you've highlighted maybe in the last month at the beginning of the year?
Yeah, I'm actually a retina specialist too. So I probably spend, frankly, most of my time talking about retina problems like retinal detachments, diabetic retinopathy, macular degeneration. I do talk about eye cancers quite a bit though. So usually I describe like what an ocular melanoma looks like, how do we diagnose it, what are the things to look out for, symptoms people have. What's an ocular oncologist? Most people don't even know what an ocular oncologist is. In fact, most people think we're optometrists. We're not. We're a special kind of ophthalmologist. So some of my content is just merely educating people about who we are and what we do and how we diagnose things.
Yeah. Okay, so why don't you just give us, in your definition, what is an ocular oncologist? I know those of us in the ocular melanoma community, most of us have either seen an ocular oncologist, a retina specialist who treats, or probably some combination of the two.
Yeah, ocular oncology, like technically defined as someone who was trained in a specific fellowship in ophthalmology. Ophthalmology is a big discipline. Most ophthalmologists, well, they're all medical doctors, every one of them. They go to medical school and they do a residency, kind of more known for doing like LASIK and cataract surgery and stuff. But ocular oncology is the specific field in which someone learns how to take care of tumors of the eye, whether they're malignant or benign. And there's a whole host of benign tumors. We usually focus in on the malignant ones because obviously those are life threatening, but there's a whole set of vascular tumors and other kinds of neuronal tumors that happen in the eye. So yeah, someone who's an ocular oncologist technically is someone who's done a whole year or a couple years learning under someone who is also an ocular oncologist. They learn how to take care of things like eye melanoma, retinoblastoma, lymphoma, tumors on the ocular surface, tumors that surround the eye in a structure we call the orbit, or tumors that are deep within the eye. But there's so few of us that have done this, a fellowship. So there are a lot of people who take on various aspects of ocular oncology. For example, there are cornea specialists who will work with in the ocular surface realm. They'll treat things like ocular surface squamous neoplasia or conjunctival melanoma. And there are oculoplastics doctors who like might do a blepharoplasty or facelift, but if an eye is full of cancer, let's say, then they'll help out and they'll take out the eye, let's say, if it's necessary. Or if there's a tumor in the orbit surrounding the eye, then they can biopsy it and so on. And then there are retina specialists who might treat like lymphoma inside of the eye or do ocular melanoma. And all of this is to help the public. They're going out of their way to learn these special tools and techniques. So there, in other words, when you use the word, you're really referring to like one kind of person, but there are a bunch of people who join the club, shall we say, and there are some pretty well-known people actually who are retina specialists, never did a fellowship in ocular oncology, and they do a great job.
Yeah, no, I think that's totally accurate. At least in my local experience, I saw both a retina specialist who treated ocular melanoma because he was just the only one in the area who was able to do that, and had the surgical experience. But then I also like was able to find an ocular, a trained ocular oncologist who did a fellowship, I think, with like Dr. Javid. So who did you do your fellowship with when you like finished out your schooling?
I completed residency at UC Irvine here in Southern California, and I did my retina fellowship at the University of Wisconsin. I actually picked that place because I had an interest in ocular oncology at the outset. And it was one of the few retina fellowships where the retina fellow and the retina faculty take care of eye tumors as well. But I realized I need a little bit more training, so I went to the Cleveland Clinic, and Dr. Arun Singh was my mentor there. He trained me in ocular oncology, and it was a great experience. I love that man.
Well, and actually, it was the Cleveland Clinic Ocular Oncology Symposium that we met at last summer.
That's right.
When
Yeah.
when Dr. Singh had a Cure in Sight come out as part of the like advocacy groups that were there for that symposium, and that was really neat. Like I mean, I know we talk a lot in the community about how there's so few ocular oncology specialists, but it was really neat to see so many of them all in one room. Kind of makes it feel like more than there are, but obviously when they're spread around the 50 states, like becomes a little more sparse.
It makes the meetings kind of funny because you see the same people everywhere.
Oh yeah, I'm sure.
You just kind of go to a different country or different city. Whereas like in retina or like regular ophthalmology, it's huge. You'll go to a
Yeah.
conference and there are people you've never met before.
No, that makes sense. Okay, so you talked a little bit before, like about how you have done videos kind of just explaining how a melanoma is diagnosed. Why is that something that you in California are more passionate about? And, why do you think your experience in, I guess really in your region, like has helped you to identify those small lesions?
Yeah, so the usual like classic story of someone who has like, for example, choroidal melanoma in the back of the eye is that someone has like diabetes or they develop floaters, and all of these things demand a dilated eye exam. And so someone will dilate the eye like an optometrist or something, and they'll see a brown tumor in the back of the eye. And in most cases, it's big enough that it's, shall we say, obvious. It's a brown lesion, a tumor. It has body to it. It looks really thick. It's kind of dome shaped. There's certain obvious features that tell us this is a melanoma. But there are many scenarios in which the tumor is so small that it's almost impossible to decide, are you a melanoma with one visit? And depending on the geography, there are some locations of the world where people are getting their eyes looked at all the time. And I live in such a place. In Orange County, there are people getting pictures taken of their eyes all the time at Costco, Target, or other various private practices. And so that's created a scenario for me where a patient usually comes to my clinic with a very small spot or lesion in their eye, rather than someone usually showing up with like a big tumor that's so easy and obvious to diagnose. So this is something that we talk about in ocular oncology a lot. How do we discriminate between a small tumor and we can't decide, is it a freckle or is it a melanoma? We actually have terminology for this. These are called indeterminate melanocytic tumors or indeterminate melanocytic lesions. There's a whole literature which is meant to allow people to make a diagnosis. And really, there are only two ways to go about it. First one has to understand freckles. There's a huge literature about freckles. How big are they? What size are they? What do they look like? Why do freckles develop? At what age do they develop? At what age do they stop developing? So people like me have to understand this literature first before going into that conversation. But I think there are some pretty basic things to say about it. Freckles usually don't grow at all. And so one easy way to make a diagnosis, well, easy for me anyway, is to get photographs from the past. And if you get a photograph from the past, let's say a year from the visit in which I'm involved, and you see the brown spot inside of the eye and it looks almost the same size or identical to the same size at the time I meet someone, I think it's pretty confident you can say, this is likely a freckle or a choroidal nevus, let's say. On the other hand, if you see a brown spot in the past and it's smaller, let's say it's half the size, and then I look at the lesion inside of the eye today, you can pretty well claim this is a melanoma because freckles don't grow like this. There's some other clues. Like if a lesion has what we call orange pigmentation, if there's fluid underneath the retina, if it's of a certain size, at least you could suggest that this lesion has a high probability of becoming a melanoma. We consider these risk features. And that's one approach. The other approach is to biopsy it. One issue with biopsies, particularly for small lesions, is that the biopsy yield is pretty low. And also, there can be side effects from biopsying inside of the eye, particularly around the retina. If you biopsy within the retina, then there's a higher chance that there could be bleeding in the eye. And if you think about it, it could be this absurd thing like we biopsy the inside of the eye, there's bleeding, only to find out that there's a freckle in the eye. So really, for me, the most reliable way to look into this is to look at photographs from the past. And if they're not available, then we usually follow things carefully. Like, for example, if some of these risk features are present, it has orange pigmentation, etc., then I usually recommend that we follow someone really carefully, let's say every 3 months for at least a year. And there are various studies showing this, like Dr. Singh, for example, and we've published that once we feel like there's a freckle that has a high risk of becoming melanoma, in almost 90% of cases in 9 months, it reveals itself. It increases in size, and we're able to treat it. And that does not confer any additional risk of mortality if we just watch for that brief period.
Yeah, just to give yourselves like that added security. And I mean, I think it makes total sense if you think about the world of medicine. Like, I think I just have kind of grown up understanding and feeling like most doctors kind of live by the rule of we want to do the least harm possible in order to treat the problem or to address whatever the problem might be. So it makes sense. Like, I mean, I think that it's easy for us, like as patients, to just be like, well, I would just like a concrete answer, right? Like, I just want you to biopsy my eye. But it also is important to take into account what you said, like that the eye is it's a very delicate little organ. Like, if you poke holes, little tiny holes, like that can cause more problems than we need, especially for something that turns out to be benign.
Right. And the retina is like the most vascular organ in the body, practically. There are blood vessels everywhere. I've seen biopsies that have led to bleeding, and you wonder, was that even a good thing for us? But yeah, so that's why, to me, at least the way I was taught, the way I tend to approach it is just watch over time, see if it does behave like a melanoma.
Dr. Oakey, you have talked a little about diagnosing these small lesions and using the historical pictures that patients have had taken, which I feel like just emphasizes at A Cure and Insight, we really emphasize to patients, to family and friends, when spreading awareness about ocular melanoma and proactively diagnosing. Obviously the best scenarios are going to be when we have the smaller lesion. I think historically, most of the studies that we've seen from Coog, from, independent studies between, doctors like yourself, Dr. Singh, we're seeing those smaller lesions are easier to treat and also easier to have, that lower mortality rate in terms of, is it going to spread later down the line?
Yeah.
Obviously never a guarantee that if it's small that you'll never have to deal with cancer ever again, but it's just a lot better of a chance. That's kind of my understanding. So you have these pictures that you wanted to share. So let's just go through some of these examples and you can just walk us through what do these small lesions look like? Because I feel like this could be really, really helpful to somebody who maybe has an indeterminate spot that they're watching.
I totally agree. So I just wanted to show shall we say, a standard, pretty obvious melanoma looks like. This is a classic example. This is the right eye of a patient. And off to the left side, you kind of have to, everything in the eye is opposite. On the right side of the screen is the lesion, but it's off to the left side in their eye is what I mean. There's a brown spot here. It's kind of off-whitish, but it's largely brown. There's a little bit of fluid underneath the retina. It's dome-shaped. It has body. To us, this is a pretty clear sign that there's at least a lesion of some kind of concern here. And then if we do an ultrasound, this is an ultrasound of that spot. It looks hollow on the inside. These are, shall we say, if you were to describe a tumor on the inside of the eye to even an ophthalmology resident, they'd say this is concerning for a melanoma. And someone like me, with a lot more confidence and experience in this field, would say, oh yeah, that's a melanoma. We need to treat it. But then you have lesions like this one. If we look at it, first of all, this is someone's left eye. There's a brown spot there, but there are certain features about it. First of all, its size. You can actually use little internal rulers to say what the size of it is. From here all the way over there, It may be like, let's say, 6 or 7 millimeters in its largest width. There's also these little orange spots within the lesion, and there's also a little bit of subretinal fluid there.
I have a question. When I'm looking at this picture, like I see the circle and I see like kind of the reddish orange and the yellow all around it. I can see all the veins, and then in the middle I see kind of like what looks like a kind of bluish gray, maybe greenish mass area. Is that the part that you're referencing as the tumor, or is it a different spot in the eye?
That's right. That brownish spot in the middle, that is the tumor that we're trying to answer. Like, are you a melanoma or are you a freckle? And you can see it underneath the blood vessels of the retina. The choroid is where these things develop. The choroid is a large layer of blood vessels that sits underneath the retina. And within that spot, you're right, there's like this kind of bluishness within the middle, but just above that, there are these like little orangey deposits. It's almost like you're digging for gold and you see the gold kind of sparkling out of the dirt. There are like these little orangey spots kind of showing themselves. And then on the bottom section of this lesion, there's almost this transparent white looking thing. That tells us that there's fluid underneath the retina. So the question we have is, are you a melanoma or are you not? It's not nearly as obvious as the prior image. The prior image is this big thing, dome shaped, it has mass to it, whereas this thing it looks pretty flat, but it has certain what we would consider concerning things. That's a question. We diagnose it by looking at it, comparing old photos, or we could biopsy it. And just to list, like, what are the risk features that we talk about? We talked about the orange pigmentation. This is one of them, little subretinal fluid. We found that lesions that are above 10 millimeters in size tend to have a higher risk of becoming a melanoma in the future. There are some publications suggesting that if it's close to the optic nerve inside of the eye, that constitutes another risk feature, and then its thickness. And the way to look at the thickness of any lesion inside of the eye usually is with an ultrasound. So we don't have an ultrasound image here. We're just going off of how it looks clinically. Now, the interesting thing about this lesion is on the bottom left here, if you can see it, there's a date. This image was taken July 27th, 2021. And if we fast forward a year later and compare this lesion, what do we see? Well, the biggest thing we want to look for is growth. Because remember, nevi, freckles, they don't grow, whereas melanomas do. And you could cause a lot of confusion here. You could look at this thing and make one image larger than the other and say, oh, it looks bigger than the other, and therefore there's a melanoma present. And we don't actually do that because we don't want to be confused. We want to diagnose accurately. And the way to diagnose accurately is to look at points of reference within the eye that are shared no matter which camera is used, no matter what year, and that is blood vessels. So if you look at the blood vessels of the lesion in 2021, and then you compare their location relative to the edge of the tumor in 2022, you'll see that this thing hasn't changed in size. In other words, this is a freckle because a melanoma would have grown over that year that goes between the photos. So all I'm trying to point out here is that even though there are some features that tell us this lesion may have a high risk of becoming melanoma, it is not in fact a melanoma. But I have an example in which actually a melanoma did develop. Yeah.
For this patient, like you said, you monitored like someone who has something that you're questioning. You have, cause to investigate further. You said you would image that eye like roughly every 3 months.
Yeah, particularly for something like this. Yeah.
Okay, so then after you hit this year mark and you had, okay, I've got a solid year, there's no growth, what happens after that point? Did you just send them on, like, do you send them on their way, or is that someone who you still recommend seeing pretty regularly?
I would still recommend seeing this patient because there's so many risk features for it to become a melanoma. We have various calculators and scientific research to reference to ask what is the probability of a lesion like this becoming a melanoma. It's much higher than average. The incidence of a freckle we estimate to become a melanoma is about 1 in 8,000, all freckles. But if you look at individual freckles like this one with fluid underneath the retina, orange pigmentation, etc., then we probably believe that the chance of this thing becoming a melanoma is much higher compared with like a standard Joe Blow average freckle. So in that case, I usually say you're still in my clinic. In fact, depending on the circumstances, I might even recommend that we check it out twice a year, just out of excess caution.
Yeah, for sure. Okay, well, I think that makes sense.
I have another example in which this whole process led to me diagnosing a melanoma. I want to show it to you. So this is another patient. They had known that they had a freckle in the past and they were starting to lose some vision. And I got a text message from my friend. She said, my patient is losing vision. He has a freckle in the eye. Can you have a look at the lesion in the eye? And I said, I'd be happy to. Anytime someone is losing vision, that is, there are symptoms from a freckle, this may also be another risk feature that we consider. And this was the spot in this person's eye. Now, in order for me to diagnose a melanoma, remember we have two ways we can go about it. We can biopsy this or we can look at it over time. And it just so happened that this person had photographs taken at an optometry practice in town. And so I called them. And this is the photo that they sent to me. So I met the patient in 2025 and they showed me a photograph from 2019. So here was the lesion then. If you look at just the bottom aspect of that spot, already there's a little bit of orange pigmentation developing. So to me, at the time, this would have been, let's say, a different kind of freckle, one that we'd want to pay attention to. And since it was a photograph that was about 6 years old, now I can look at it and compare its size over the course of time. And here they are. So the one on the right is my patient today, and the one on the left is my patient 6 years ago. And if we just very carefully map out all of the little blood vessels and make a comparison, this is what it looks like. I put little white dots where the lesion used to be 6 years ago. And if you look at the border now, you can tell this thing has gotten larger over the course of time. So this is one way to diagnose melanoma. And again, if we just review how it looked in the past, there's spots of orange pigmentation. So this would tell you that there's actually probably a higher than average chance of becoming a melanoma in the future. And even at the time I met the patient, this is an OCT scan. Over the lesion, there's a little bit of fluid underneath the retina as well. I have another example of this. This is a patient who was told that they had a freckle years ago, and the patient was referred to a retina specialist, and the retina specialist did the right thing. They looked at it and they said, this is the size, let's follow it over time. But then it started to develop orange pigmentation and fluid underneath the retina. On the image to the left, you can see that they're like little tiny deposits. Again, I think of this like gold inside of dirt. Like if you're a miner and you're looking for gold, you just see these little sparkles. It's the same thing with this color photograph. You can see these like little orangey deposits right by the center of the macula there. And then if you scan over the tumor, there's a little bit of fluid off to the right image. Of course, you can make out the body of the tumor underneath the retina there, but there's a little collection of fluid there. And at the time I met this patient, I'm going through the same mental process we were talking about, which is I need to get an old photograph. Unfortunately, the retina specialist who referred the patient, he was really busy that day, but my patient pulled out his cell phone. And this is something that our patients can do too. If we're sitting here talking to the public, one should be interested in getting these photos. Well, this guy just had a picture from his phone and he pulled it out. And here was the image 4 years before I met him. So if you go through the same analysis, you look at the edge, the border of the tumor in 2021, and then you compare that with 2025, it's pretty obvious that this thing has increased in size. And I even outlined it here, like on the image of 2025, you can see these little white dots where the border of the lesion used to be compared with where it is in 2025. And this is what we do. If we see a small tumor, we want to know, has it increased in size compatible with a melanoma? Well, it's pretty obvious that it has. And one might suspect, even in 2021, there's a little orange pigmentation. There's a little risk feature there that this thing should be followed carefully.
I think it's interesting, like looking at these two pictures side by side, that like the first one, the 2021, I guess on my screen at least, I don't know about you guys listening, but on my screen, it looks kind of more like almost greenish.
Yeah.
Like the colors that I see on the screen look more green. Like I can see a few of those kind of like little deposits, like you said, like the kind of more orangey brown areas, but it's not as prevalent in the color. But then in 2025, like honestly, if you had shown me the 2025 picture just alone, I probably would have been like, well, that doesn't look like much. Like it looks like all the same color, like, but the shadow underneath it is definitely more distinct, and the coloring seems a lot more like to the brown side as opposed to like the green side.
Yeah, the image technology is always different. This is why earlier I was saying like a lot of times a photograph will be taken at some other clinic by a different kind of camera with different optics, and therefore you have to use universal points of reference to assess whether or not the tumor has increased in size. Like the image that was taken off to the right in 2021, that was using an Optos camera, which has a red-green laser scanning technology, whereas the one in 2025 that was taken in my clinic with the same camera, except it has red, green, and blue scanning lasers. So when you add a blue hue, it actually makes the image look more realistic. Whereas if we go back to, like, for example, this image, this is an image taken using a completely different camera. This is a Canon camera, and it's a true flash. So that's why oftentimes when we're talking about these kinds of images, we have to, in the mind, kind of subtract away some of the distractions. And some of the distractions really are the color in a way, although orange pigmentation is a very prominent thing we look for. But like if a tumor looks browner in the past and it looks brighter in the future or vice versa, those might be a distraction based on even not even just the camera technology, like which camera was used, but like if the patient is closer to the camera or further away, then the image, the light might actually reflect more from the eye, and therefore it can look brighter or darker depending on what happened. Also, people can have cataracts, people can have a dry eye, and that can make the image kind of fuzzy, for example. So the mind has to kind of get rid of some of these distractions and look at the very basic details of like, what are we concerned about? Fluid, orange pigmentation, but mostly, primarily, the size, the border of the lesion over time.
Yeah, absolutely. That makes sense. I love that you said that this patient was able to pull up the picture on their phone. Like, I was someone who, the very first time that my eye had a picture taken, which I regret to say was the time that I basically had a retina detachment. It was a retina detachment due to the ocular tumor growing so big. That was the first time I had ever seen the inside of my eye in a picture versus just a dilated eye exam report. And I took a picture of that, and it's crazy to like look at that picture versus the healthy eye. It's like obviously something is very wrong.
Yeah.
Like, and but I mean, just in having those pictures to track, and also just having the ability as patients to like advocate for, you know, within our own care and be like, okay, like, can I take a picture of that just so that I have it? That's such a smart thing to do. Like, I just think that's really, it's got to be helpful. Like, just especially if you're kind of in a situation where you're really feeling like pretty reasonably certain that this is a melanoma, like now you have in-office confirmation that you can feel more confident in moving forward.
Totally. And I always advocate this for my patients, particularly the ones who are moving. Like, I have some patients for whom I don't know yet if they have a melanoma. I just met them, and they'll be telling me, "Oh, I'm moving to Florida now." And I think it's my job to provide them the tools necessary for someone else to take up the baton so that there can be a future comparison. In fact,
Mm-hmm.
I'll even identify someone in the place that they're moving to, and I'll say, I know this person. I'd like to communicate with them. Do I have your permission to share images? And then I also provide my patient with the highest resolution image possible. In fact, on my practice website, when an outside doctor wants to refer patients to us, we have a protected section of the website where you can just drag in images from a computer so that you don't have to mess with faxes and all sorts of low resolution images. We want the highest res possible.
That's super cool. Technology has advanced so much. You've given us some really good examples, but if someone has one of these kind of initially indeterminate lesions, it sounds like, you know, just in summary, that the best thing for them to do is to either pull up past imaging if that's possible, continue getting imaging like regularly, and to just track it over time.
That's
And
right.
then proceed with treatment, obviously, if that became something that needed to be addressed.
And I think another important variable is the person with whom you're working, the physician. you really want to find someone who has experience with this because sometimes the growth pattern is not really readily recognized with someone who might be well-meaning but doesn't have a lot of experience, no, to, like understanding what we're talking about. Even though a lot of things we're talking about seem pretty simple, there are some complexities here. So finding like we were talking about, like a retina specialist who is able to treat this or has a lot of confidence and experience with it, or even an ocular oncologist, this is where you really want to monitor these kinds of things because the moment there is any detectable melanoma, you want to be able to treat it or at least know how to get to treatment.
Yeah, that makes sense. Okay, so you mentioned just a couple of key things that patients could look for in a new ocular oncologist. What do you think makes you someone who patients should want to come to, and like what do you also look for if you're referring a patient who's moving out of state, like in another ocular oncologist or practicing physician?
Yeah, what I'm looking for is someone's educational background. Like, I feel like most retina specialists, for example, are equipped to understand a high risk lesion versus a low risk lesion. So that's what I'm realistically looking for, at least in most cases. There are a lot of states that don't even have an ocular oncologist. And especially if I know them, like I know that they're a really good person, they're really thoughtful. I like to be a guide for them. And if you're starting off and you don't know anyone, then it's good just to meet the first ophthalmologist you can find and say, hey, I have this spot in my eye. What do you think? Do you know anyone whom you trust who can have a look at this? That would be one approach. And of course, if you live in a place where there's an ocular oncologist, it's probably best just to meet them. So
Yeah, absolutely.
why me? Well, you know, I'm a handsome guy, I think. No, I'm just kidding. No, like I said, I've done a fellowship in this stuff. I feel like I understand it really well. There are other people in my territory, like in Los Angeles. There's Dr. McCannell, Dr. Barry. There are various people that work with Kaiser Permanente, like Dr. Cedar. These are great people. And in fact, a lot of times people come to my clinic and I inform them there's a melanoma in the eye, and my patients will say, I'd like to have someone else weigh in. And I feel totally comfortable with that because I know that my colleagues in Los Angeles or even San Diego, they have aptitude and the training, the experience that we're talking about that's necessary to make a diagnosis.
Yeah, absolutely. With patients, like you have been practicing, like you have a private practice in Irvine, and you see patients in that local area. What do you find, like over the last few years, and throughout your fellowship, as you've learned from Dr. Singh and other doctors? What do you find are the best approaches for breaking the news of an ocular melanoma diagnosis to as a patient?
I learned this really early on, actually from a Current site. I went to a conference. First of all, at the very outset, I've been able to deliver some tough news just as a retina specialist, like telling people you're going blind. There's nothing we can do about it. That's tough news, of course.
Yeah.
But seeing my mentors discuss this issue has been really helpful. But as I was saying, I learned this really well from someone who's a member of a Current site. When I was at a conference, I was talking to someone who had ocular melanoma, and she told me something that I don't forget, which is that when her ocular oncologist told her she had melanoma, she didn't hear one word he said after that. And I feel like that's a pretty common experience. Most people don't even know that people can get eye cancer. Like, they don't even think they will get a cancer, let alone in the
Yeah.
eye. And to imagine all the implications of having a cancer in the eye, it can threaten a very important sensation, but also threaten someone's life. That's a lot to swallow. So
Yeah.
when I deliver tough news, first I like to show someone on what basis am I making this statement. I have the photos in front of me. In all my exam rooms, I have these big TVs. I have the photograph from the past. I have the current photograph. And before that, I even educate people. This is what we're looking out for. Now let's look at the photos. And we see that the lesion has increased in size. And so I ask a very basic question. How else do we interpret this? This is a melanoma. And usually at that point, I like to tell people we have a lot that we need to talk about, but because we're really talking in some heavy subjects here, I usually like to suggest let's end the visit right now. Obviously, call me if you have any thoughts or questions between now and next visit, but if you could give it like a week to let some of these ideas simmer for a minute, maybe think of some questions when you're not feeling so nervous and hot, I found that that's really helpful. In fact, I've had patients, I had a really smart patient working for one of these big aeronautic firms in LA County. I remember this patient told me, I have no questions at all. I just want to get to treatment. And just being me, trying to be a kind, understanding person, I said, I completely understand that, and I'm prepared to talk about whatever you'd like to talk about. I take all the time we need. But in the final analysis, I did recommend to him, like, can we just give it like a week or so? I know you're going to have some thoughts that you're not going to be able to have right now. And then he revisited my clinic about a week later and he said, you were right. I wasn't thinking clearly at all. And he came back with like a whole list of things and we talked about it. I think that's a good, pretty universal approach. I find very few exceptions to this like thing where someone comes back and they say, I had no thoughts. I wish we would have gotten to work when we first met. Hearing this tough news, I think is like the language we use is important, of course, but just giving someone a lot of breathing room because we're in a hot, confined room. The exam room is like the door is closed. People feel kind of confined in some situations. So giving people a lot of room to kind of think things through, to me, is like a really important ingredient to the whole conversation.
Yeah, I think that makes a ton of sense, honestly. And I think, when you get, I mean, just as a patient myself, like when you get that diagnosis, the feelings that come up, I think there's the shock, there's kind of the denial. I think there's plenty of patients who do what I did, who like want another opinion. And, when you have that time where you can get another opinion, you can, feel out two different doctors, but also, like you said, have that room to breathe in accepting your diagnosis, even just at the very surface level of just acceptance of like, okay, I have this, now what? Like, I think that becomes that can become a really pivotal point for patients in their ocular melanoma diagnosis journey. So once they've had that, initial, you told them the diagnosis, said, okay, we'll talk more about the plan, but like, I need you to take a week, come back, let's talk a little more, and we'll talk about, what's the next plan or the next step in the plan. How do you approach that next, kind of prior treatment visits?
Yeah, the next visit is almost always like a let's get down to business visit because usually after a week or so, people have kind of wrapped their mind around it. They visited a cure site. I tell people all about it. Even Facebook groups, there are people on TikTok talking about their journey, and a lot of people have looked into it and they realize that this is a real thing and it's happening to them. So by the time they come back to my clinic again, it feels like we're just going to get down to business. Like people want to talk brass tacks pretty quickly. I have a lot of patients who tell me, wait a second, remind me how this happened. So we almost always revisit the pathophysiology, like the pathway of disease progression. How does someone develop a freckle? What are the risk features of a freckle becoming a melanoma? We almost always cover that. And that's where we have to kind of break a little bit of the 21st century mentality. A lot of people in the 21st century want to point their finger at something or someone or whatever and say, this is what caused my melanoma. It was this injury I had in high school or Vietnam or whatever. I hit my head and that's why I got a melanoma in the eye. We have to confront that and break some intuition that we think we have, but we don't really have. That almost always happens. But then the brass tacks, we get down to that too.
I feel like that's so universal for cancer in general, though. Like even if it's not eye melanoma, like that's just everybody wants that answer, right? You want to know, well, why did this happen? And I think that's one of the hardest things to accept as a cancer patient is you may never know exactly why. Like on a physiological level, sure, we can explain what changed, but we can't necessarily explain why or what triggered the change. And I think that can be a hard pill to swallow. I definitely have seen patients get hung up on that. For patients who are listening who maybe are in that spot, what would you say to them to kind of like help them through so that we can just move from that kind of fixation maybe to let's take action here?
Yeah, I agree. It can be, you could describe it as a fixation for sure. I think it's actually one of the most fundamentally important questions that we deal with. And so what I try to do is reintroduce someone to the idea that we live in nature and we are frail humans trying to understand how nature works. And there are many things in nature that we don't yet understand. Number one, and there are influences that we have no control over. Again, this is breaking the 21st century mind because we pull out our iPhone and we think we have control over the universe, but we don't. So I have to introduce to people conceptually the process of developing a freckle, a single pigment making cell. When it replicates, it can make an error in the DNA. The DNA can mutate. And with further mutations in the DNA, then one of these freckles might become a melanoma. It's almost statistically probable that some people will develop it. The 21st century mind has a hard time grasping that. And of course, when we talk about like what is reported in the literature, it's almost absurd. You look at what is associated with eye melanoma, it's like fair complexion and a blue eye. That describes like billions of people.
Yeah.
That describes you, that describes me, and many other people on the earth, you know?
Yeah, but it absolutely doesn't explain some of the more rare demographics of people who I think that was something that you mentioned when we talked before is that you, like in Irvine, California, you have the opportunity to see some of these more rare demographics of patients. Like, what are just a few of the, I guess, the categories of like ethnicities and people that you've seen, just to kind of break that stereotype? Because I think that
Oh,
can
yeah.
be maybe validating for patients who are in the less common group.
It definitely is a stereotype of, I mean, if you look at the incidence of eye melanoma, people with a fair complexion definitely predominate the number of people who have it. But nevertheless, people without a fair complexion can get it. In fact, today, I will be doing a radioactive plaque for someone who's of Japanese ancestry. In Irvine, in Orange County, we have a, a wide variety of ethnicities. There's a large Vietnamese population in one city. Being in Southern California, there are a lot of people who have immigrated from Latin countries, and there are people who are African American, for example. So, yeah, I definitely see a difference in the way a melanoma appears in the eye as compared with someone of a fair complexion. Particularly for African Americans, it can definitely happen. It's quite rare, but the tumors tend to be much darker. They tend to be diagnosed late for various reasons, whether they're socioeconomic reasons or the tumor wasn't recognized early on because it's so dark as compared with the complexion of the back of the eye. So it definitely presents some challenges for sure. And this is where we utilize all the tools that we have, the basic tools. Do tumors grow over time? Biopsies can be helpful. In fact, we usually draw more from biopsy technology in certain instances.
Yeah, that's super interesting. Well, I feel like we could talk so much more about, obviously we could talk about the treatment process. We could talk about after treatment happens. But I do want to just kind of reiterate as we close, as an ocular oncologist, at what point do you refer to a medical oncologist, like someone who's going to track scans, watch the liver? At what point do you see that kind of being the most effective transition?
Yeah, you're in ocular oncology, you'll see a wide variety of opinions on this subject. The way I was trained and the way I understand the best use of medical resources and patients' time is to assess the tumors that have the highest probability of developing metastasis. And at that point, involve a medical oncologist. So this would include people with like a large uveal melanoma or someone who has high risk genetics. If both are present or either are present, I usually ask a medical oncologist to join the screening team. But for like, let's say a small melanoma of low risk genetics, an ocular oncologist is usually well suited to do liver metastasis surveillance. We have a whole literature describing like which technology is best used, like whether it's ultrasound, liver MRIs, et cetera. So we draw from that literature, a lot of experience, but also, at least in my practice, and I know very few exceptions to this, the highest risk lesions usually go to medical oncology. And the other really important facet of that is that the ocular oncologist works closely with the medical oncologist. I demand that I have everyone's cell phone. I usually text people with my patient's permission. This is my patient. They're coming to you. These are their genetics. This is the tumor size. I even ask my patients, can I share you the images with them so that they can see what the original tumor looked like? Because usually medical oncologists don't look inside of the eye at all. They don't even know what we're talking about. By the time a patient shows up in their clinic, it's just a normal looking person. Maybe the eye's a little red and that's it. So
No, I think that's such an important distinction to make. And that's actually something I've never even thought of. In most cancers, you see a medical oncologist and they are both responsible for the primary tumor and for surveillance. Well, our primary tumor is in the eye. It requires some kind of an eye specialist to treat it.
right.
And then you go to medical oncology and they're like, I just feel like I can see that being a disconnect that could be, it would be interesting, I think, to like see if you put doctors' heads together more, like I know is happening, obviously it's happening more and more in ocular melanoma because as ocular oncologists and medical oncologists, you guys see the benefit of working together. But I would just be really interesting to see like what we could learn from putting our heads together in that setting, like from the moment of a primary like high risk tumor. It'd be interesting to see what that could lead to.
Yeah, like I said, I demand it. I'm very loud.
I mean, I think that's a really good thing to have in a doctor is someone who's going to advocate, for you and with you. You guys, like if you're listening and you didn't know about Dr. Oakey, please head to our physician finder on acureInsight.org. You guys can actually connect with him, get in to go and see him at his clinic. If you're planning to move to that area because you just, want to live close to Disneyland, like make sure you go and say hi to Dr. Oakey. We've talked about this on a few episodes, but we do have this physician finder. And so if you're listening to this YouTube channel, this is your first opportunity of hearing from us at Acure Insight. Please head to our website. If you can't find it, you can go ahead and send us a message at a contact@acureInsight.org, and we will help like locate a physician close by. But I mean, that was something that Dr. Oakey and I really wanted to highlight was that, there are doctors, there are physicians from coast to coast. Like there really are ocular oncologists from east to west and everywhere in between. Like it's just a matter of finding them and, finding the network of people who, they know each other and they refer to each other.
Totally. I have everyone's cell phone.
Oh, yes. So that's good to know. Good to know. So now I have your cell phone. So if I have somebody that I need to get a hold of, I'm going to ask you. So if patients want to connect with you on TikTok or they want to just follow your TikTok to learn about, what's the channel called? And can we also include that in our description?
Oh, yeah, of course. The one on TikTok is the name of my practice, which is Blue Coast Retina. I also have my name on Instagram, Dr. Zack Oakey. I have a Facebook account. I have a YouTube channel as well. That goes into the handle of Blue Coast Retina. In this world, it's kind of hard to figure out handles and account names
No,
and stuff.
I feel like that makes sense. And we'll make sure to link, these different things as well. For those of you guys listening, if you want to go and check out his practice or check out his YouTube channel, TikTok channel, all those different ways. But Dr. Oakey, thank you so much for being here and for sharing your expertise and, making yourself known to the patient community. I feel like it makes a huge difference.
I appreciate the privilege.
Awesome. Well, I just want to give a huge shout out to our sponsors. We couldn't do this podcast without the help of our sponsors. Please use these kinds of resources if you can. Use them to help in explaining things, right? Like we as patients don't have to bear the load of explaining our diagnosis, explaining how our diagnosis happens. And thank you again, Zack, for just all of your references to what we do here at Acure Insight and your willingness to, collaborate with us and to help patients find us. We really appreciate it.
I love it.
Awesome. Well, we will see you guys next time.